Again, greetings. Thank you for joining us. You've tuned into the Systems for Action research program at the Robert Wood Johnson Foundation and our recurring webinar series, Research in Progress webinar series. My name is Glenn Mays. I'm a professor here at University of Colorado, and I direct the National Program Office for the Systems for Action research program. If you are new to our program or new to this webinar series, we're a national research program funded by the Robert Wood Johnson Foundation, and we study ways of helping medical care, public health, and social service systems connect and work together and align their efforts in ways that can address the priorities of improving health and health equity in American communities. We fund studies all around the country and study a whole variety of ways of helping medical, social, and public health systems align their efforts and work together. We look at ways of aligning funding streams and financing mechanisms and payment models. We look at ways of aligning delivery systems and implementation strategies, information and communication networks, governance and decision-making strategies and structures, and with the goal of building the evidence base about how to make systems work better together toward our common goals of advancing health equity. We typically come to you with this webinar series twice a month, and we feature one of our research projects funded through the program, give you a chance to find out about what's happening in that research and lessons learned. We also occasionally have special guests who join us, other people outside the program, but doing related work in system alignment and related kinds of activities. And that is the case in today's session. We are really fortunate to be joined by colleagues Dr. Susan Goold, who's based at the University of Michigan in School of Medicine and School of Public Health, along with a colleague of hers, Zachary Rowe, as well, to talk about some innovative work that they're doing around supporting collaborative system-level shared decision-making and deliberation, specifically around resource allocation issues, which are often at the heart of collective action problems. And so we definitely need innovative new ways of helping us to solve those problems. Just a few housekeeping issues. We always record these sessions, so we're recording today's session, and after the session, today's webinar will be archived up on our website at systemsforaction.org. We will have time for questions from our audience today, and we encourage you to use the Q&A box or the Q&A icon that you see down at the lower part of your screen on today's Zoom session. You can click on that icon and type your question into the Q&A box, and we'll get to as many of those questions as we can toward the end of today's session. If we miss anybody's question, we can follow up with you by email after the session today. With that, I'm going to turn it over to Dr. Goold to get us started today.
Let me unmute myself first, and thank you. And thank you for inviting us to come and share this with you. I know this is a research in progress seminar. This is actually sort of a report of research we've already done and research we're hoping to do. So in that sense, it's in progress, but it's not like we're in the middle of something. And I'm here today with a longtime colleague of mine, Zachary Rowe, Executive Director of Friends of Parkside. And in fact, Zachary, I think I'll let you introduce yourself.
Okay, great. My name is Zachary Rowe. I am the Executive Director of the Friends of Parkside. I'm a co-founder of the Detroit Urban Research Center. Also, I serve as a co-PI on the Deciders Project and a community consultant on several projects and steering committee member on numerous community-based participatory research projects and partnerships. So I'm going to go more into my history in a few minutes. But thank you. Thanks for having us.
Okay. So we're going to talk today about engaging communities in setting priorities for health and our plans to disseminate a successful method for doing so. And I'd like to acknowledge many who have supported us, including the Robert Wood Johnson Foundation. I was a Robert Wood Johnson Generalist Scholar many moons ago. Picker Commonwealth, various foundations and institutes, and some resources from the University of Michigan. And of course, partners, really too many collaborators to mention here, but want to especially mention my co-inventor and co-investigator in many projects, Marion Danis, the Decider Steering Committee that Zachary will tell you a bit more about, the Center for Health Communication Research at the University of Michigan, Yeti CGI, a software firm, a development firm in Michigan, and many, many collaborators and co-authors. I'd like to disclose, hence the sunshine here, that the University of Michigan, the NIH, which has helped to support the development of this, and myself and Marion Danis, who was an employee at the NIH, may benefit from paid licenses and royalties, none of which we've had in the past 5 years. So, Zachary, take it away.
Okay, thank you. Okay, all right. So I think for me, and Susan and I were discussing this earlier, it's important to set the context for the Deciders project, the Deciders tool. And the best place to start is at the beginning. One of the things that is not apparent, or maybe it's going to become apparent, is Susan and I have worked together for many, many years. And how we started to work together is an important part of the story. But before I get to that point, I want to sort of backtrack and talk about the Friends of Parkside. I would be remiss if I didn't spend a few minutes talking about the history of the Friends of Parkside. So the Friends of Parkside was started in 1991 by 5 women of the public housing complex called the Friends of the Village of Parkside. Important thing about those 5 women is that none of them had a high school diploma. My mother, Catherine, served as the first executive director for the Friends of Parkside. And she served as executive director for up until the mid 2000s. And it's a testament to the organization that the organization is still around all those years. And so with me, I think it's important for me to always tell that part of the story because it's important and it's powerful, right? And also the reason why I told that story is that, during those years, during those late 1990s and early 2000s, and I think I started this whole presentation by sort of saying, hey, I'm the executive director for Friends of Parkside. I'm the co-PI of this and this, that, and the other. I could never remember in all my time having researchers sort of come and ask us what was our priorities, right? I was intrigued when a colleague of mine introduced me to Susan Goold, who had this amazing tool called Chat, and she was interested in refining that tool in order to allow community to come up with their own health spending priorities. Now, this was huge for me because, like I said earlier, I've been involved in numerous research projects, and every proposal that we got involved with, someone had already defined what those priorities were. And for the most part, those priorities that we were responding to really didn't align with those problems and issues that was in my community. More importantly, if someone would have the vision to come and sort of ask me, hey, what was important for my community, I couldn't really tell you the answer. And so when Susan proposed this idea of the chat tool, I was hooked. And I'm going to say the rest is history, but I'm not going to say the rest is history because the history has still been written. And so for the first couple of years of that project, Susan and I, we applied, it seemed like everywhere to get funding for that project. We came up with this analogy about kissing a frog because we kissed a lot of frogs initially before the project was finally funded. But it was finally funded by NIH. It was built on the principle of CBPR, community-based participatory research. With that said, we wanted to make sure that the project and the people around the table reflected the goal of the project. And so for me, it was important because, you know, here I am coming from a minority community, right? We want to get to the next slide. And our steering committee reflect the principles of the tool and of the partnership. We have a statewide community project. These are our wonderful steering committee. Some of them been with us since 2010. Some of them has just started with us less than a year. And we are now called a long-standing partnership. That means that we outlasted the first round of NIH funding for the most part. Okay, next slide. Okay, all right. And so this slide is important because it sort of captures the key principle of CBPR. One goal of CBPR is to make sure that when you engage in communities, the community is involved from the beginning, that conceptual idea or coming up with a research question all the way to the very end in terms of disseminating the results and everything in between. Also, this project also builds on participatory design, whereby the community is involved in designing what it would sort of look like. And so throughout this presentation, we're going to talk about ways that community was involved in shaping this tool and shaping this project. Also, we have community partners who actually serve as trainers for this project. And so this has really been an incredible project for me. And that's why I've been involved for the past 15 years. Next slide.
Okay, so one of the questions we need to answer first is why engage the public in setting priorities related to health? Well, this first box is in quotes because we're starting to hear more and more from policymakers and healthcare leaders and research leaders that we need to engage the public in making important policy decisions, including those related to resource allocation or priority setting. They don't always say what they mean by engaging the public, and they certainly haven't always described how to do that, but we have developed this tool and have reached beyond technical experts to lead to allocation decisions that are more legitimate and enjoy greater public support. So if you engage communities in setting priorities, those priorities may be better accepted and supported by the public. Engaging the public in setting priorities can also contribute to earning, building, and sustaining public trust in institutions. I think this is something that has become glaringly obvious during the pandemic, that having trust in public health, healthcare, health research institutions is crucial. And also importantly, that it can incorporate the knowledge of community members that might otherwise be inaccessible to decision makers. So communities, however, may not engage in setting priorities. For one thing, sometimes these questions or these issues really lack salience for many people. Nobody really cares what their health, well, they care a little bit, but they don't care about all the things that their health insurance may cover or all the ways that public health spends money. That lacks salience for many people until or unless they're confronted by illness or public health emergency or something like that. Participation in policy may not be viewed as a priority for people who have competing demands on their time and effort, and people may not consider themselves well informed enough to participate in this kind of sort of direct participatory policy. From the other side, people who want to engage communities in deliberations about health priorities, there's a huge need for information when you're talking about health, public health, healthcare, science, research, and that information can be complex and very technical. You also need to be able to imagine, or your deliberators need to be able to imagine their own and others' future health needs. So not just what I need today, but what I might need in the future, what my neighbor might need in the future. And making trade-offs between competing health needs can also be somewhat intimidating, emotional and frightening. If you're talking about, you know, who's getting a scarce drug, for instance, that's not always an easy conversation to have. And then what method to use to engage communities in deliberations about health priorities. And so we developed the method for informed deliberations, sorry about the S there, about health priorities. And informed deliberations, based on theories of deliberative democracy, is really for policy issues that benefit from direct public input. It's often the case that since policy isn't about individuals, that group deliberations are recommended. So if you're talking about the use of limited public resources for health research or limited resources for health care in the form of insurance coverage, those are decisions that affect not just one person, but a group of people or a community of people. And informed deliberations really are about what we should do as a political community and not just what do I or what do we want. So when you use surveys, for example, to find out, how people would trade off different health needs or health resources, you're asking an individual for their opinion based on their preferences and values. But in group deliberations, informed group deliberations, you're asking about what we should do. Also, because of the informed part of informed deliberations, there's no need for a lot of pre-existing knowledge of a topic. So we developed this chat, Choosing Altogether, which is an award-winning serious game, or sometimes called a simulation exercise. And this engages non-experts, people who don't know anything about health resources, in informed deliberations to make trade-offs individually and in groups between competing needs for limited resources. This used to be always done in person. During the pandemic, we developed a completely virtual version of the tool, so it can be done either way now. And we have had multiple projects that have successfully engaged people from minority, low income, urban, rural, and other underserved communities. The tool automatically collects data for both individual and group selections, and there are lots of other ways to collect data, but that is done automatically by the software. So here's, this is not the current image of chat, but chat has gone through a variety of iterations from, hard copy to CD based and then all kinds of stuff. So here's an earlier one, but it's a nice illustration. So the spending categories, these wedges here of the chat board or the chat wheel, these are the spending categories. So in this case, this was a project about Medicaid spending priorities in the state of Michigan. And, meds and supplies, specialty care, dental care, all the usual things that are sometimes included in Medicaid spending, but also things like eligibility and cost sharing and resources for quality and equality. The layers of each of these wedges represent different levels of investment. So your basic level of investment in, let's say, primary care here would be 2 out of your 100 markers. If you want a higher level of investment in primary care, you would have to spend 7, and the highest would be 10 or 10% of your budget. So this is the budget. We specifically don't use dollars, but we use some markers to indicate relative costs of things. Basically, more markers, you're spending more of your money. And then people do this at first as individuals, even though they're in a group. And then they will see health events, stories really distributed by chance in some way to illustrate the consequences of their spending decisions. So let's see if it'll Oh, it's not. So usually when I hit this thing, it'll spin around and show you how it works. But okay, I don't get that today. Anyway, let's say, for instance, that it lands on the access category. And that event might illustrate how far you have to go in order to get access to a particular health service. Okay, so this is a complicated slide, but this is the whole chat process. There's an introduction, some instructions, kind of a description of the task that they'll be given. People do a pre-chat survey. Um, there's typically an educational video that describes the information they need to be able to do the task. For health research priority setting, it was like, what is research? Where does the money come from? And how do they decide? And that sort of thing. Then in the first round, individuals choose priorities, see the consequences of some of their priorities, and discuss that with the group. Not always, but sometimes we have small groups of 2 to 4 people do this also together. Again, spin the event wheel to see the consequences and discuss with the group. And then finally, the whole group, which typically is between 9 and 15 people, although we've had smaller and larger than that, will choose priorities as a group led by a facilitator. And we use professionally trained facilitators and preferentially community members as facilitators often. In round 4, we have them choose priorities again as individuals, and this is basically so we can see if they change their minds. That's a research aim and a post-chat survey. So you can see that all these white arrows are ways that we get quantitative data from chat sessions or chat projects. And we also often collect, actually just about always collect qualitative data, especially in round 3, to look at the reasons for setting priorities a certain way. So we've had a lot of projects about health insurance. The right box is a bunch of publications. You all will get the slides so you can look those up if you want to. We've had projects about basic or essential benefits, about private insurance, about Medicaid, Medicare, coverage for the low-income uninsured in communities, projects in India, Switzerland, and New Zealand. This middle one here is the very original hard copy chat game that nobody uses anymore. And the picture at the bottom was the project in India. We've had some projects about health research priorities, the Deciders project that sort of got the steering committee started, and also a project through PCORI about priorities for patient-centered outcomes research. And we've had some projects more in the past, well, a little more recently, about community health priorities and social needs. So what should be the priorities of not-for-profit healthcare organizations for community health benefit spending? They are required to engage communities in community health needs assessments, but not in deciding which of those needs to meet or to prioritize. So we developed a version of chat that could enable engagement of communities in those decisions, the so-called implementation strategies. There have been a project about employment benefits for low-income workers, so trading off health insurance versus vacation time kind of thing. Our most recent project was about community priorities after COVID, and that was where we tested the virtual version of chat. And I was not part of this one, but someone looked at nutrition interventions in rural Ghana. So there have been a lot of different projects, and we have a fair amount of evidence from these different projects about what using chat allows you to do. First of all, people find it understandable, fun, and informative. I can't say having a focus group about health insurance benefits would be considered fun by most people, but this one is. There are favorable views of group deliberations. They tend to say they feel respected, that they had a chance to say their point of views and that sort of thing. Participants would often be willing to abide by the decisions made by their groups and trust the process to inform decision makers. They gain insight into limited resources and express concern for the common good. So in the reasoning they give for certain priorities, they will talk not just about what I want, but what we should do or what would be good for others. And some of our exploratory work suggests that the results of community deliberations about priorities can influence decision makers. And here's a couple of quotes based on what some of what people said about participating. I loved getting different opinions, some things I might not have thought about. So people often talk about having their minds opened a bit. So the latest project we've done is community priorities after COVID, and we finished data collection and we're still analyzing data for this one. I've grayed out the faces of the participants here, but this is a combination of the chat board, but also Zoom didn't work for this. We used something called Jitsi. I don't know if you've ever heard of that. And here are the markers down here. So it's a little bit harder to see than some of the previous ones, but people seem to find it still useful. And again, we had entirely virtual group deliberations in both English and Spanish. So the whole thing was translated into Spanish for some. And we recruited low income, like many social science-based projects in health and healthcare, you get more women than men. And you can see in the race and ethnicity column here that we really did have a nice distribution of different races and ethnicities. In particular, our American Indian or Alaska Native, this is way above the percentage in the state of Michigan. So, and post-chat measures, again, we're still analyzing some of the data, but the views of deliberation, which is a scale we've used in many projects, they rated quite highly. It was between agree and strongly agree. And information and choices, not quite as highly. Willingness to abide by the group's choices and trusting a process like this to inform decisions about government spending, all pretty favorable. We are, by the way, looking at, because of the virtual method of this project and the ability to have people from different places engage with each other, we're also looking to see if having more, that ability to have more heterogeneous groups could make people more willing to listen to other points of view and change their mind. But stay tuned. That data is yet to be finalized. So what we've been working on, we started working on it pre-pandemic, but the pandemic kind of interrupted a lot of things. So we've resurrected it, if you will, is to disseminate this method to other places. So we're planning a multi-site dissemination and implementation study to develop and refine the resources, and including probably some generative AI that would make the chat method both the tool and the participatory process of developing the content easier to adopt and use. So whether it's for research or for policymaking or community organizations or community health benefit for a not-for-profit organization, we want to make this easier for people to just, access a library, if you will, of resources, training resources as well. And we want this project to contribute to the science of community engagement by letting us study whether engaging communities in priority setting in this way, does it affect awareness, knowledge, and understanding? Our previous projects would suggest yes. Trust in health systems, in health research, public health. Does it affect relationships with academic partners? Because we are really focused on disseminating this, at least in this project, later on to other places, but disseminating it to community academic partnerships. Does it affect allocation decisions? And through all these other things, does it eventually, probably not in the typical 5-year research project timeframe, but does it also affect community health and health equity. So Michigan obviously is one of the places that that will be involved. Colorado is another, although with the caveat that we haven't yet been able to get confirmation from community partners. They've been very busy with some SEAL stuff and we're hoping to talk to them before mid-May. We've been in conversation with Chicago community partners and academic partnerships there, and potentially other partners. So if your community academic partnership is interested, just reach out, let us know. Okay. So lots of stuff. Any questions, comments, suggestions, ideas?
I just want to jump in, Susan, just
Oh,
sort of say
please.
that, I just want to say that all the slides that Susan shared is the work of the community partners and the Decider Steering Committee. And so we were involved at the very beginning, like I said earlier, throughout this whole process. Yeah.
Mm-hmm. And I will say that as Zachary mentioned early on, community partners have been involved in developing the content. One of the things that we realized early was that whoever's writing the menu controls the decisions in lots of ways. And so we brought community partners and decision makers in earlier to help us create a menu of spending priority options that were meaningful to communities, but also could be actionable by decision makers. So kind of trying to walk that line a little bit. So questions. I've got some in the Q&A here.
Yes, we do. We are open to questions now. Again, we invite folks, if you haven't already, and you've got a burning question you'd like to ask, Susan and Zachary, please type that into the Q&A box down at the lower portion of your screen. We already have a few questions, so I can tee up a few of these for
Great.
our speakers. First question asks about how this work might relate to concepts and approaches around learning health communities or learning health systems. Have you given that any thought about the connection of this tool or how this tool might support that that set of activities?
I'm not sure, and I'd love to hear from you all about how you think this might connect with learning health community or learning health systems. So, yeah, I hadn't ever really I have some collaborators in learning health systems at the University of Michigan, but I hadn't really thought of it as sort of connecting to that directly.
Good. Well, that's an area for further thought.
Definitely.
Question about compensation of participants for their time in engaging in the chat process and methods. Are any approaches for how to manage those issues, which is always something issue that often will come up in participatory types of research projects.
Right. So, Zachary, do you want to answer it?
Well, definitely. In terms of compensation, we definitely believe in compensating folks for their time. It goes a long way just in terms of building trust. So yeah, definitely. But then also when we do chat sessions, we also try to recruit community partners to be chat facilitators. So it also has that economic development opportunity for those communities that are serious about chat and they want to get their academic partners trained in running the chat sessions.
Yeah,
Fantastic.
and I think the follow-up to that question was something about ensuring representation from underserved populations, which has always been our emphasis. And as probably many of you know, it's not always easy. There are competing priorities for their time and attention. And so having community partners help with that is important, but we've also learned a lot about sort of where and how to advertise and how much to compensate people and how to make the the game is fun. So I don't know. Zachary's done a number of these at Friends of Parkside, and they're like, when are we going to play chat again? So
That's fantastic to hear. Um, some more questions. A question about whether this model has been used with providers and with more of a focus on, priority setting around improving health outcomes.
mhm,
Is that a context in which the model has been used, or would you see it having some applicability in that space?
mhm. So the chat exercise has been used in educational settings and in some demonstrations to um, a variety of folks besides communities. So students in health administration or health policy, students in medical school and nursing and pharmacy or whatever. In fact, interprofessional education methods. It's also been used for sort of stimulating conversation amongst decision makers. So one of the first times I demonstrated chat was to this group of executives from Fortune 500 companies. And first of all, they once they heard when and we had gotten our cost data, they said, okay, just take 5 markers away because it's more than that now. But so decision makers, we did a demonstration with AARP and different sort of kind of advocacy or community-based organizations. So not sure how it would relate to providers in improving health outcomes. I do think that how you set priorities for the use of limited resources has some pretty obvious connections to health outcomes. If you have some drugs researched and not others, or if you have drugs researched but not non-pharmacologic methods of treating people, or if you have, insurance coverage for some things and not others, or so there's obviously a lot of ways that could come into play.
Fantastic. And a question about, so is this tool available to other communities, and how can other communities who might have an interest get engaged in this work?
Yeah, reach out and contact us. In fact, I didn't include our email addresses on the slides, but I will perhaps one of the whoever's distributing the slides can just add my email address to that. And if someone's interested in using it or learning more about it, we can follow up with that. So, and no, the use of chat is not limited to community academic partnerships. The project we're planning for dissemination implementation project, we think that's a sort of a good way of doing that sort of dissemination implementation. Um, but no, using it, chat itself is not limited to that.
Fantastic. Another question asking about, can you provide more information about how the menu is developed
Mhm.
in this process?
Yeah. So, I showed you the chat wheel and the categories and levels and stuff like that. And um, we, we really bring the decider steering committee and, depending on where the project is happening, other community partners involved um, in helping to develop that menu and decision makers. So, for example, for the research priority setting project, we had on our steering committee, besides community partners, we had several leaders of scientific institutions, our CTSA, Institute for Gerontology, the Detroit Urban African American Aging Research Center, and because we wanted the choices also to be something that could be acted upon. So we would have ideas for, okay, what about this category? And how do you lump and split? And how do you decide what's sort of the basic level and how do you, so that's all involving community partners and to some extent decision makers to do that. So
Fantastic.
We're hoping to make
Um,
that easier too. So,
that makes very good sense. Another question asking about how this tool might be used as part of hospital community health needs assessment processes
Mm.
and or public health agencies' community health improvement plan processes. You mentioned a little bit about that, but say more about, your thoughts in that area.
Yeah, I mean, when we first started that project in Michigan, one of the things that we hoped to do was, so first of all, the content is created. If you wanted to use it, you could tailor it a little bit, I suppose, but the content is there. It's pretty um, self-explanatory, and um, we have some resources for training facilitators and that sort of thing. Um, I do think that that actually is a use of the chat process that has a great amount of potential. Setting local health priorities. I think local organizations may well be more responsive than, say, oh, I don't know, Congress or NIH. Okay. So I think that's has a lot of potential. So yeah, they have to engage communities in the needs assessments. I think this would enable them to engage communities in which needs are most important to meet. Zachary, do you want to add anything to that?
No,
Yeah.
I think you covered it. And I also dropped sort of the direct link to the community health benefit page that's on the website.
Mm. Mm-hmm.
Fantastic. Thank you for doing that, Zachary. Couple of questions about recruiting participants.
Mm-hmm.
And one question, but how did you achieve such success with recruiting such a variety and diversity of participants and attendees?
Mm-hmm.
And was the virtual option part of that strategy? And
Mm.
just more, can you say anything more about your recruitment strategies here?
Right.
Yeah, I think, but basically we leverage our community partnerships initially. Since we had community partners around the table, and of course your partners have partners. So and so we try to leverage that network as much as possible. In addition to that, we also use some other creative method like Facebook and Craigslist. And we really got
Mm-hmm.
creative over the years just to see which method would yield the best results.
Mm-hmm.
And by far, the going to community partner network is the best.
Mm-hmm.
Because folks from the neighborhood trust community partners and will
Mm-hmm.
respond. There was another
It,
question, the virtual option.
yeah.
Yeah. So Susan mentioned the virtual option really came because of COVID. Initially, we were doing chat in the same room, even though we had a local network and we had a local server. The push to make it virtual came because of chat, because at
Mm-hmm.
that point, folks did not feel comfortable being in the same room, and we still
Mm-hmm.
had to we still had to implement the project. And also our local server died. So what you saw, the last chat board that you saw was a rebuild of the entire chat because some things are a blessing. So the fact that we had to start from scratch was kind of a blessing because it allowed us to sort of build that infrastructure so that it really truly is virtual.
Mm-hmm.
Susan, I don't know if you want to add to that.
Yeah. Well, and I do think actually that the virtual, recruiting for the virtual version was in some ways more challenging, in some ways less challenging. Okay. So when you're doing in-person stuff, that means you really have to recruit enough people in, say, a small town in the Upper Peninsula of Michigan to have a group, right? But if you're doing it virtually, you can bring that person in with people from Mid Michigan or West Michigan or Detroit area or whatever. Um, so I think that made it easier in some ways. People didn't have to be in the same place at the same time. It made it a little more challenging in some other ways because although the digital divide is, you know, narrowing every day, really. It was still, we had especially a special difficulty recruiting folks for Spanish language sessions. Okay, not just Hispanics, because we had Hispanic ethnicity people in English language sessions, but
Mhm.
recruiting people to attend Spanish language sessions was more challenging. So our Charo, our steering committee member, used her WhatsApp network and everything else. But yeah, what Zachary said, using various ways of reaching, and we've learned from our community partners, okay, you can use a newspaper in this area of Michigan, but not in this one. You can use a radio station to reach Spanish language speaking people, that kind of thing. But it's, there are challenges.
Yeah. And I just want to piggyback. The going virtual created some real challenges for us because, like Susan said, the digital divide is real. And so we never had to deal with sort of the technology infrastructure around chat until we went virtual. And so now we have to deal with other issues in terms of whether or not they have the bandwidth, whether or not they have a internet device, whether or not they know how to use it. So going virtual created a whole new set of issues that we didn't have to address until we went virtual.
Very, very good. Another question asked about the time frame and scope of engagement. Can you say more about how long this process takes? What kind of time commitment?
Yeah.
Single sessions versus multiple sessions over a period of time?
Right. Well, it could be used in a variety of ways. We have, like, for instance, if you were going to do a community health benefit project, you could, in fact, use the tool over the years with different groups of people or same groups of people or whatever. The chat exercise typically takes around 2 hours. And most of our projects have been doing multiple chat groups. So for instance, the health research priority, we had 47, I believe, groups, and, between, 9 and 15 people in each. And yeah, so public deliberation processes are sometimes different from that. They'll sometimes be all day events or half day events with breaking out into smaller groups and then coming back together into a very large group, like an auditorium full. But um, the the chat process is different. It's typically smaller groups, multiples of smaller groups.
Very good. That's very, very helpful. Just a couple of other questions here. Question about, again, another question about availability of this chat method to others. Chat is not a part of the S4A program. Our colleagues here, Susan, Zachary, are special guests that we've invited to present on this work because of its relevance to a lot of the projects that we have going and looking at ways of stimulating collaboration and alignment across systems. So again, encourage you to reach out to Dr. Goold and colleagues if you might have an interest in learning more about the tool and the approach and making use of it in your community context. And just a reminder that we record all these sessions. If you have missed today's session or want to go back or share today's session with others, an archived version of this webinar will be posted on our Systems for Action website shortly after our session at systemsforaction.org. It looks like we have been able to get through most of the questions. So again, I want to thank you again to Susan and Zachary for giving us a tour of this really exciting tool and process and how it's being used and your plans for the future in terms of making use of this. I hope we can stay in touch with you all and your team about how this work progresses. And again, we'll make sure to, as we email out materials, make sure that your contact information is available.
Yes, that's
in
great.
case any of our participants today might want to reach out for more information. So thank you both
Happy
so
to do it.
much.
Thanks for having us.
It's been wonderful learning more about you, this great work. Thank you both, Susan and Zachary. We will definitely stay in touch.
Yes.
Thanks to everyone for joining our webinar today. Again, stay in touch. We do this, come to you twice a month. We'll be having another research and progress session later in May. You can find more information about our schedule of upcoming webinars on our website. Our next one you can see featured here on this slide will be Wednesday, May 8th, we'll be hearing from our colleagues from the Coeur d'Alene tribe about their research projects on a tribal care coordination system developed there as well. So thanks so much, everybody. We'll look forward to staying in touch and enjoy the rest of your day.
All right.
I,
Thank you.